I performed in year 2001. This is a picture from operative theatre and pre-operative planning. And here is the result in the operation table. The flap is revascularized, and I measure temperature and oxygen mount continuously post-operatively. And this is the result after 2 years. Sorry, I go still back. In this delayed breast reconstruction, it can be done after 2 or 3 years after mastectomy. And this vascular pedicle, which is inferior epigastric artery and vein, which comes from femoral artery and vein, this is a dominant pedicle, and it goes through this rectus abdominal muscle with several perforants. And the nerves follow the vascular perforants. And then here up I prepare recipient vessels. First I made it from axillary area to thoracodorsal vessel, but later on, after I visited Queen Victoria Hospital in London, I changed it to inframammary vessels. And in case I have a patient with vertical laparotomy and no other tissue for reconstruction, I can use those both bilateral vessels for revascularization of the flap. The immediate breast reconstruction is possible with this abdominal flap too. And then I take the whole glandular tissue away. Here is the picture about it. I take nearly always nipple with it because I use this immediate reconstruction in those cases when I know that there will not be any radiation afterwards. And most of them are intraductal carcinoma in situ. In case the tumor is intraductal, so it has open way to spread to mamilla, and that's why I take it away and reconstruct it later with a small flap, and then areola will be calculated. And this is another immediate reconstruction case. Those long islands lose some of their sensibility, but this abdominal skin is visible only in this mammillary area, and it will be covered with calculating, so aesthetic result is the best possible. So first, by muscle sparing trunk and not the egg. It was because those nerves follow vascular perforators, and I wanted to spare so many healthy nerve branches as possible. When I started this neurovascular tram flap breast reconstructions. And after 20 patients which I had operated, I evaluated the situation. And 20 patients which has 3 MS tram flap, for them I had prepared 1 neural anastomosis at the site of the vascular pedicle. Then I compared the sensibility return of the breast to those 20 other patients which I had operated during the same period but without nerve anastomosis. And here is this promising result. I could see that with neuroanastomosis I could get a significantly better, double better sensibility return to breast than without neural anastomosis. This is a picture of Yap et al. Study. They made cadaver dissections, how nerves form branches and connections, net-like connections in lower abdominal area. And that explains why I could achieve with only 1 nerve anastomosis totally sensing breast with every test as we had in our pilot work for a few patients. But on average it was only half, so I was not satisfied. I wanted to go further. And like I said, in our pilot work, I sutured from this vascular pedicle site 1 neural anastomosis. But now I started to do bilateral neural anastomosis. I prepared from opposite side another nerve for anastomosing them later on here up. This is this inferior epigastric artery and vein, and you see I have tried to draw in the picture that nerve branches comes through the same perforance than blood vessels, so they are easy to find. And I prepare this more part of the muscle to the flap. And here in breast area, I make a pocket ready for the breast, and I prepare the vascular pedicle first. I used to take third or fourth from the third or fourth rib, a small piece away, and underneath you can see inframammary vessel. Normally they are in touch. And then I prepare them for anastomosis, and in case I should use thoracodorsal artery, I make it into axillary area. And I find those intercostal nerves inferiorly, third or fourth thoracic nerve, which I prepare ready for, I take only one, but one of them for nerve anastomosing. And then I seek from axillary area and other nerve for anastomosing before I cut this flap for vascularization. And those 3 lowest intercostal nerves gives sensation for the whole lower abdominal area. Here I have dissected from vascular pedicle side 11th and 12th intercostal nerve and here is vascular pedicle, even you can't see it very clearly. And the rectus muscle is still continuing, but I take a small part of it with these branches. And from this other side, I prepare another nerve. I do it like this section because I know that this nerve goes along the perforant. I choose one perforant and then I dissect the nerve. I make a small opening to fascia and then dissect the nerve as far as it is possible for later nerve anastomosing. And as a recipient nerves in axillary area, you are breast surgeons, you recognize all these nerves very well. Especially this intercostobrachial nerve, which gives sensation for brachial area, is very useful. And then you know that at the bottom of the axillary fossa there is another vertical nerve, which is the branch of 6th intercostal nerve. And then there comes intercostal nerves through pectoralis muscle, on the side of pectoralis muscle. And in case they all are lost after mastectomy, they are sure there is this thoracodorsal nerve at the bottom of axilla, which goes to latissimus dorsal muscle. And from this inner side, there are also available to find third or fourth intercostal nerve. Those recipient nerves have suffered from mastectomy and radiation and axillary evacuation, and I have measured that it diminishes some of the sensibility return, but they are still always, there is always many of those to choose.